Welcome, Dental XP. Thank you for having us again for another webinar Wednesday. I want to thank Tyler Binner and Eddie Salama for organizing this and getting us involved. Dental XP has become one of, or the premier online education sites, and it's really just great for people from all over just to gain great knowledge and have wonderful speakers available to them. I have the pleasure of having with me today Brian Chadroff, who is a periodontist and new to Dental XP. He is a periodontist that I work most of my surgical cases with, very, very talented, and we're really fortunate to have him. Thank you for coming, Brian.
Hi, Mike. Thank you. Happy to be here.
So today we're going to go over some innovative sequencing on how we perform our interdisciplinary aesthetic cases together. And we're really going to focus on how to improve the treatment duration for the patient, the patient experience, and really how we improve the communications between ourselves, ceramist, and patient. So today we're going to start with a traditional interdisciplinary approach, and we'll show you how traditionally we have approached these types of cases. And we'll go through specific concepts involved at every step of the way.
We're going to review aesthetic crown lengthening with a very novel approach, trying to get a little bit of innovative sequencing to get better control of the case, as well as getting better communication between the restorative dentist and the periodontal specialist. We're also going to talk upon perioplastic surgery, and we're going to review connective tissue grafts and the use of alloderm and full arch root coverage, again, with innovative sequencing.
And then I'll discuss certain restorative aspects, again, always generated from the facial aesthetic standpoint. And you can go back, I did a two-part series on facial aesthetic design that really shows the breakdown of each of how you look at a patient's face in order to gain the framework of the position of the smile. So everything is going to be facially generated in terms of our treatment plans. And in the end, we're going to go through and show you some innovative ways of how we're sequencing these types of cases in order to benefit ourselves and the control of the case and really to benefit the patient experience. I think in anytime someone is asking for aesthetic dentistry, as aesthetic dentists, as restorative, as periodontists, we are controlling the way they look, the way that they're perceived. And we really have to have some sense of our own perception of beauty. And I think it is sometimes overlooked, but a very important factor in being able to look at our patients with confidence and figuring out a design that we ourselves are saying, this is how I think that you should look. And I think it's a very powerful aspect of our profession, and we're very fortunate to be able to control something like this. Simply defined, beauty is the phenomenon of the experience of pleasure through the perception of balance and proportion of stimulus. And what that really means is that when we have the perception of beauty into our lives, we're really perceiving something in its harmonious form. So if we're talking about facial beauty or architectural beauty or beauty in nature, it's eliciting some form of symmetry to us that we're processing as being beautiful. And when we're really designing these types of cases and we're treatment planning and we're trying to do the best for our patients, what we're really doing is we're trying to set up harmony within the patient's face. So we're trying to set up facial harmony. And we control probably the most prominent feature in the face, which is the smile. And most times it involves an interdisciplinary approach in order to get it to where we really want it to be. In 1995 in Newsweek, they did a cover story on the biology of beauty, and it said that One key to physical attraction is symmetry. Humans, like other species, show a strong preference for individuals whose right and left sides are well matched. And what that's really saying is that, we perceive human facial beauty from a sense of harmony overall on their facial features. Unfortunately, probably 95% of us don't have perfect symmetry from left to right. It's very rare. And knowing that we don't have that type of balance in our face, it allows us, when we're designing the teeth, in order to pull that symmetry together by figuring out where the asymmetry lies and then trying to balance out that asymmetry with the new position of the smile. And that's really the kind of the crux of what we're doing in dentistry, in aesthetic dentistry in particular. So rather than traditional dentistry where we sit the patient down in the chair, we go into their mouth and we start looking at dental problems, we really have to back up and design from outward in and look at our patients' faces and say, okay, well, we're going to design around the framework of the face, which is going to lead us into some general knowledge on smile design, which will then lead us into creating individual tooth forms, which is really dental anatomy, which is what we've been taught since we were in dental school. So just to kind of review quickly on facial aesthetic design, for every patient that comes in, we want to go through this facial analysis. And this is really creating the three-dimensional framework of where the smile really needs to be. We're always using the facial midline to create and find the dental midline and parallel the dental midline to the facial midline. And then we're using a kind of horizontal perspective from the interpupillary plane to try and figure out the position and direction of the incisal and gingival planes. Next, we're going to look quickly at the relation of thirds of the patient's face. We're really controlling the lower third of the face to try and figure out what we need to do dentally in order to harmonize that lower third of the face. And we're going to look at parameters of how we define the buccal corridor in terms of where we build the buccal corridor to, knowing that patients are not symmetrical from left to right, lends us to knowing that the buccal corridor also cannot be symmetrical from left to right, because we're really trying to use the buccal corridor with the teeth to really parallel and frame the position that the angle of the mandible is creating. And this was an article that was written for Inside Dentistry in 2012 on facial aesthetics that you can go back for a reference as well. So designing from the face to the smile to the tooth form will always get us in the right position to create harmony at every step of the way. And you take a look at a patient like this, and we're really first facially figuring out where the smile needs to be, and then figuring out the actual design of the smile in relation to the facial features. And from that, we're able to figure out the individual tooth form in order to harmonize the patient's aesthetic needs. So how do we get from kind of point A to point Z in these cases? Because most of the time in today's advanced dentistry, we're not simply dealing with a restorative aspect and a laboratory aspect. They begin to need surgical aspects in order to enhance the soft tissue and or need implant therapy. And therefore, we have to be able to control the aesthetic blueprint from the very beginning, keep it consistent throughout the treatment plan, be able to control the communication between all parties involved, including the patient, and really have a clear direction in order to get to the execution. So, figuring out where we need the teeth to be in the first place should be on the restorative aspect, who's going to be planning out the position of the smile. It's then that we understand when and where we're going to need, interdisciplinary, whether it be orthodontics or periodontal enhancement surgery or implant therapy, and then being able to communicate that both to the patient, to the specialist, and to the laboratory, and then being able to execute along the way. And I think that the way Brian and I are approaching cases now, we've kind of changed the order of operations that traditionally have been used for some types of periodontal therapies included in these interdisciplinary cases. I think that we have started to try to push the envelope to make it an easier line of communication between the restorative and the specialist, and also an easier line of execution for the patient as well. So we take a look at our first case, and again, we're always looking at a facially generated treatment plan. And we can see off the bat where we need the position of the teeth to be. So looking at the facial midline of this patient in regards to the dental midline, you can see the dental midline is canted to the patient's left, and also the patient is showing more soft tissue on the patient right side than the patient left side. So we know that we're going to need to change the position of the soft tissue. The question is how much and if we'll need hard tissue crown lengthening versus soft tissue therapy. And then upon radiographic examination, this patient presented with pain. Upon radiographic examination, we see the failing apical.
So this patient had a chronic endodontic failure in this area and probing approximately 9 millimeters on the facial of the right central incisor. As you see, the right central incisor is already more apical than the left central incisor. So this tooth is hopeless and needs to be extracted, so we need to plan for some site development, because not only are we considering to place either immediate implant if possible in this area, but we need to control for the possible soft tissue loss in this area.
The traditional interdisciplinary approach that we take on this case is we would look at an aesthetic restorative evaluation, and we would figure out dental problems like the failing upper right central. We would see the axial cant and the restorations, and we would see the excessive gingival display at full smile, which would turn into needing a periodontal evaluation.
So when we evaluated this case periodontally, we also know we need aesthetic crown lengthening, but we liked the position of the upper left central incisor. So everything was going to kind of play off that. So the key here was we need to remove the upper right central and control for any soft tissue loss, see if we can place an immediate implant in this area, account for provisionalization of this tooth, and then go into our aesthetic crown lengthening.
So we created a treatment plan that we would address the patient's problem first, which was the pain in the upper right central. We would extract that and try for some type of immediate implant placement. We would then follow that with crown lengthening on the upper arch, and then restorations on the upper 10 to 12 teeth, depending upon how wide was the smile that we designed. We ended up doing the upper 10 restorations.
So the patient presented to my office for surgery for the extraction of tooth number 8, and we reflected a full thickness flap, and you can see there is good interproximal bone, but just as we expected, there was a severe labial dehiscence all the way almost to the apex of that tooth. So the consideration was, do we want to graft this site first, or do we want to try to place an immediate implant if I can get that in stable, and then graft upon that? I find that if we have good interproximal bone and I can stabilize an implant into this site, it's much more advantageous to me to try to graft against that implant surface. So we place a 5-0 internal hex implant as palatally as possible into this site, and then we grafted the gap with the mineralized freeze-dried bone allograft, and also grafted, as you can see, approximately 7 to 8 threads, which were exposed on the facial surface due to this dehiscence. Now the consideration here was, do we use a conventional method with a membrane of some sort for guided bone regeneration, or can we use a thick connective tissue graft as sort of our membrane, because the real concern is that we do need to bulk up the soft tissue. So we chose to use a thick connective tissue graft to try to bulk up the soft tissue and also give us some form of guided bone regeneration. So the patient, we were able to achieve primary closure, as you see here, and really bulk up the facial aspect. The patient was advised, because we're using more soft tissue there, that the chance of having to require a second connective tissue graft was very likely. And the patient was sent off to Mike's office so he can provisionalize the area.
So at this point, the patient shows up, and we're going to have to figure out a way of provisionalization. Obviously, if a conversation between Brian and I was said that, if we thought the implant was stable enough, we would load the implant immediately. That would give us the best chance at, starting to sculpt that site into where we want it. Unfortunately, we didn't think that was a good idea at the time of surgery, so I created a 2-unit bisacryl temp that I knew I would need something to be able to take on and off, because we're going to have to do some site development in that area in order to bring that tissue exactly where we need it to. As well as really trying to regenerate some of that distal papilla. So here in the slide you can see we're sounding the crest of bone on the distal aspect of number 8.
What I advised Mike, though, that because we had good interproximal bone, I was fairly certain that we would actually be able to regenerate that distal papilla, because there is good interproximal bone there. So that was something I was not too concerned with. Had we had horizontal bone loss in that area, or a vertical defect and interproximal bone loss was present, we would have difficulty in trying to place that implant, because we need to get that papilla back.
Right. So really, from the restorative aspect, we're just trying to figure out where we're going to put the contact point on that provisional restoration to ensure that that is indeed regenerated. Here you see the bridge bonded in place, the contact point created, and then after 6 weeks healing, you can see that we're starting to get great papillary regeneration on the distal aspect of number 8. However, we are starting to get that kind of slumping of the apical tissue from where the surgery was done, and therefore we know we're gonna have to go back in and be able to remove that provisional, polish it, and send the patient over with the provisional out of the mouth so that Brian can go back in and place another soft tissue graft.
So at about 10 weeks now, we're going to go in and try to bulk up that soft tissue to create an ovate site and develop that site. We did a full thickness flap, and again, another thick connective tissue graft was placed over this site, and the flap was coronally positioned, and closure was achieved. And you can see the bulk that we were able to have to develop this soft tissue site over our healing implant.
Now the patient will come back to me, and what we'll try to do after post-op is we're really going to try and sculpt that provisional in order to create that ovate pontic site, to put a little bit of pressure in there to start for that tissue to kind of sculpt around where we want the final margin, soft tissue margin, to be around the implant restoration when it's done.
I always try to overbuild that facial area so that we can develop this ovate pontic site and sort of get the restoration to emerge out of the soft tissue.
So this is about 8 weeks healing now. We're ready for hard tissue crown lengthening. And the question here when it comes to these types of cases where we're not only changing apical height of tissue, but we're changing apical position because we're changing the direction of teeth. When you have these axial cants involved, you not only have to know apically where the position of the apex of the tooth is going to be, but you have to know the axial inclination of the new tooth and where you want it to be. This is where some line of communication becomes disrupted between even the restorative dentist and the laboratory in order to get a wax-up back, and especially the restorative dentist and the periodontist who's doing the crown lengthening. We tend to try to be as hands-on as possible to allow as little as possible to be uncommunicated, and therefore we've done it different ways. This is going to be a direct markup, a live markup, where I'll go to Brian's office and actually draw on the patient's tissue exactly where we want the zenith to be for those initial incisions. Another ways that we've done it is we've done direct mock-ups, which is we do an aesthetic provisional application where we're bonding the final form of the tooth directly on top of the patient's existing dentition, which will show us where the apex needs to be. and that can be done with a wax up as well.
For me as a periodontist, it's very important to have something visual. Of course, we take all the original measurements and know exactly what the final tooth length is going to be for each one of the teeth involved. But it's very good to be able to see something visual. In fact, before the advent of facial aesthetic design for me, I rarely was able to see the cants that actually were in place in many of these cases. In this particular case, there's more gingival display on the right side, the patient's right side, than there is on the left side. So we're going to be needing to remove more tissue. We visually want to show that so I can get a feel for where I want the gingival apices to be and also how much tissue I'm going to be removing. That's done exactly with millimeters. However, we do this visually to get a feel for what that's going to look like. Again, this is all done with the patient's interpupillary line. So then I go ahead and make my initial incision on each of the individual teeth, using the visual display to give me some feedback as to where we are. And the patient really feels very important, as the patient experience is really good when it's possible for Mike to be able to come to my office during this surgery. And when he's not there, we rely on these bonding mock-ups that he provides me with. One of the things that we see in this case, which I see very commonly on aesthetic crown lengthening, is we see a lot of this buttressing bone that's present, as you see here, in the buccal quarter regions. This bone needs to be removed to really get a good restoration. It's almost as though the bone is facially cantilevered over these restoration. This is a patient that has previous veneers in place, and so we've decided what the final tooth length is going to be above those veneers, and then I need to blend in that osseous crest. So there's really two parts of this that we're really going to be dealing with here. And again, on the other side, it's the same thing. Again, buttressing bone, exostoses, ledges, whatever you want to call, it's often there, or probably approximately 70% of the time in these cases, I see that there. So we're going to horizontally remove this bone with osteoplasty, and then come in with ostectomy and really try to smooth out that alveolar crest to get right to the final tooth length vertically so that we do not violate biologic width. And here you see the closure that's in place at the time the patient's going to be leaving the office.
So 8 weeks from there, we're able to start the restorative aspect of the case. And just to kind of recap what we've done thus far, we've had tooth extraction, implant placement, connective tissue graft. We've waited 8 weeks to go ahead and place another connective tissue graft. And we've waited 8 weeks and done the crown lengthening. And now we're 8 weeks out and about to finally get to the restorative. And as you can see, the patient here through the surgeries has had to wear this Bizacryl temporary for probably about, let's say, over 25 weeks. Also is showing the root exposure from where the crown lengthening surgery was done for 8 weeks. So, in terms of patient service, it's something that if we're going to try to be able to resolve with not having to have the patient go through this type of aesthetic healing. Like every time, what we're going to do is this direct aesthetic provisional application rather than a wax up. And what direct aesthetic provisional application is trying to gain the final tooth form prior to preparing the teeth. So it's really an addition reduction mock-up over the teeth to gain final form. And we'll go ahead and we'll take an impression of that to use as our temporary stent and preparation stent. Then we'll go in and prepare the teeth and uncover the implant. We uncovered this.
It's important to do these uncoveries without any kind of flap approach. You want to preserve the soft tissue that you're able to build up. Here we either use a laser or some sort of punch technique to preserve as much of the soft tissue as possible.
So here we are going to do this with a soft tissue laser right at the time of preparation, and then I'll place final impression coping, take our final impression, and then use a preformance abutment that I can sculpt the provisional into the soft tissue exactly the way we want healing to occur. We do this outside of the mouth, sculpt it the way we want, and then bring the patient back the following day, which is crucial in communicating both the final aesthetic outcome with the patient and the final aesthetic outcome with the laboratory to make sure that everyone's on the same page. And then we'll show this to the periodontist, and if any soft tissue augmentation is needed, it would be done at this stage, but we have achieved what we needed to in terms of harmonizing the gingival apparatus with the dental apparatus. At this point, we will take alginate impressions, measurements, digital photographs, and this will all go to the laboratory in order to simply copy what we've done in provisionals into individual porcelain restorations. We'll be guiding the ceramists in terms of our choice of materials. Here we're using feldspathic veneers, an all-ceramic crown on number 9, a porcelain fused to metal custom abutment on number 8 that allows us to build an all-ceramic crown over the implant to try to maintain the aesthetics.
And this is at the time of insertion, but notice how nice the soft tissue healing is above our implant. By building out the soft tissue and then creating an ovate pontic into that site and now utilizing porcelain, the tissue really sculpts very nicely against this porcelain. You can see not only the nice color of that soft tissue as it heals, but it's really going to blend really nicely into our porcelain restoration.
So here we have pre-treatment photographs and our final restorations, and you see how we've really changed the position of the teeth in the maxilla, more importantly the position of the teeth in the facial form, creating this overall facial harmony for our patient. Again, to recap, this has been 3 surgeries and over 25 weeks of healing. So the question is, can we increase the control of the aesthetic blueprint throughout the case to where we put a lot of the aesthetic componentry in the hands of the restorative dentist that can show the laboratory and the specialists exactly where we need our final restorations to be? And really, can we enhance the patient experience?
In some of the cases, there is a classification system for aesthetic crown lengthening. Ernesto Lee developed one in 2004, and we could have provisionalized these cases at an earlier stage had we wanted to, depending on how much soft tissue was available below the osseous crest. But really, the whole idea is to enhance communication between the restorative dentist and the specialist, but also to improve the patient experience in the sense that many patients that have gone with aesthetic crown lengthening that have crowns in place or discolored roots are ending up with crown margins exposed and really discolored roots that are exposed for sometimes up to 8 weeks prior to the patient being temporized, depending how the case has been treatment planned. So that's what we're trying to see, how we can take this aesthetic crown lengthening procedure to the next level.
So what we're going to do is we're going to try and reverse engineer the order of operations and how these treatment plans are accomplished. And if we start with a patient like this, and the patient came in wanting to change her smile, she had previously had plastic surgery and now wanted to take care of her teeth. And interestingly enough, we want to be able to kind of locate that facial midline and horizontal perspective of the face into the position of the smile. And as we do that, and what we start to see in the initial phases of the treatment planning is that we need removal of soft tissue on the patient left, but more importantly, we're going to really change the position of the teeth to negate that maxillary cant going from patient left to patient right. So this is not easy to communicate to the periodontist, nor is it easy to communicate to the laboratory in order to get a correct diagnostic wax-up back. Christian Coachman does a great job with his digital smile design in terms of getting something back from the lab that is correct. I tend to feel that what we try and do, as we do more and more of these cases, we start to get very fanatical about the final tooth position. And if you're doing a lot of these cases, you start to realize that everyone along the way, every specialist that gets involved, every ceramist that you get involved in these cases, everybody has control into the final aesthetic. And everybody really has to be on the exact same page. And when you're working in someone's mouth, you're not working in millimeters or feet, you're working actually in microns. So not only are we talking about apical coronal position of teeth, we're really talking about, facial lingual position as well. How far out do the teeth need to be in order to be in the correct aspect for the profile of the smile, as well as the apical coronal position of the teeth. So what we do is we have devised a way to do this aesthetic provisional application in the patient's mouth to gain final form of tooth structure. And when we do that, we're able to see exactly where the teeth need to be in order to design the smile. So in order to gain this, what we're going to do is go ahead and use a soft tissue laser, and we're going to temporarily violate biologic width, do our final preparations, take impressions, seat our final restorations, and have the patient crown lengthened after a final insertion of the porcelain.
This is what would be considered normally or traditionally as an aesthetic crown lengthening case type 2, where the removal of the soft tissue to the desired tooth length will not expose the alveolar crest. So this is a good case in an attempt to try this. In addition, if you notice, this patient does have discolored roots, and so she would have normally or traditionally been with that exposure for some 6 to 8 weeks, unless she was provisionalized previously.
So with the first appointment, the patient would come in and we would figure out exactly where we want the position of the teeth to be. And in following that, we would take a soft tissue laser and go ahead and violate biologic width. And you can see here on the patient left how we're bringing really the apices up. And at the same time, when we prepare this, which you'll see in the next slide, we're going to have to aggressively prepare the incisal edges to bring the final incisal edge much more apical than it currently is in order to change the position of the smile in the patient's face. So here you see where the biologic width is impinged, and now here you see where the final margins of these teeth are placed up in this region. Now note, initially, from the incisal edge position of 8 to the incisal edge position of the canine, now note the final incisal edge position of number 8 in accordance to the incisal edge position of the canine, how aggressively we really had to prepare this lateral, central, canine, and premolars in order to end up with the axial inclination of the teeth of the desired final tooth position. So here we're going to bring the patient back in provisionals in order to go over in detail what we want the final tooth position to be for that patient. And it's at this point that we can alter any point of the provisionals in order to gain aesthetic success between restorative dentist and patient. Once we have accomplished that, and we want to really look at the patients from all angles, once we've accomplished really understanding the kind of arrangement, the incisal silhouette, the arrangement of the teeth, the prominence of the centrals versus the tucking in the lateral incisors, this type of embrasures we're going to use, this is all done in the mouth, designed by hand in accordance to what the restorative dentist thinks is most aesthetic for the patient, and then what the patient in the end ends up liking. And it's wonderful to be able to show the patient, a variety of looks for that particular aesthetic. And once this is done, we're going to be able to take photographs and impressions of the temporaries in order to send to the laboratory for them to be able to simply duplicate the facial form of function and form of the teeth into individual restorations.
Now, what's interesting here, several other people have reported, like Ernesto Lee, of developing the case up to the provisionals and then having the aesthetic crown lengthening done. We decided to try to take this case one step further and take this to the final restoration prior to having aesthetic crown lengthening. Wouldn't it be more beneficial to have porcelain there to help sculpt the soft tissue while it's healing, rather than having some form of acrylic or composite? So this is the next step that we're taking. Instead of ending it in provisionals and doing aesthetic crown lengthening at this stage, Mike's going to go ahead and complete the restorations and allow for some healing, and then send the patient to me for the aesthetic crown lengthening and the removal of the violation of the biologic width.
Yeah, so Here you're seeing the final restorations in place. This is at the patient's first recall, the day after the restorations have been inserted. And we'll go through occlusion and final form and shaping of the veneers of what exactly we want them to be, but they should be 99% correct, considering that they've gone off of the form of the provisionals. We're then going to allow this about 2 weeks to send to Brian to have the hard tissue crown lengthening performed.
So what you see here upon full thickness reflection is that the veneers are certainly violating biologic widths, especially in the area of number 11, 12, and the area of number 13. The veneer is actually touching the alveolar crest. So we start again by doing our vertical component, the ostectomy, to start to trough that area to get 3 millimeters from our restoration. In fact, the porcelain, which is our final restoration, acts as the most ultimate of all surgical guides. But in addition, we're trying to deal with some of this buttressing bone up in here, this thickness or exostosis, to try to level that off so we're not ending up with really some sort of cantilever over our restoration. So really, when we talk about aesthetic crown lengthening, there's osteoplasty and ostectomy that has to be performed. We consider that to be the vertical and the horizontal plane. As I showed before, the removal of supporting bone, which is what we do really for the aesthetic crown lengthening for tooth length, is the vertical component. And the removal of the buttressing bone, any ledges or exostosis, is the horizontal component. It's this removal of the horizontal component which becomes very, very important in these aesthetic cases to really give the right sort of dimension to that buccal corridor. And so it's very important, even in traditional cases, when you're just removing soft tissue, we're going that a lot of osseous is actually done in these cases. So here you can see the amount of bone that's actually missing in the anterior of this patient. One of the ways in which we're going to try to get a very stable gingival margin is by using enamel matrix derivative in this case. So I've been using enamel matrix derivative on my aesthetic crown lengthening cases to help prevent recession and to increase and enhance our wound healing in these cases. So we're using Emdogain, which is enamel matrix derivative. It will enhance wound healing. It enhances the reattachment of our soft tissue back to the root surface. It also has a very stabilizing effect on the gingival margin position. It also decreases postoperative discomfort for the patient and enhances the wound healing for this patient. And the key to this case is really not getting postoperative recession above our finished restoration. So that's what really makes it more important here. So here's the closure after the use of enamel matrix derivative. We're using figure 8 sutures to pull that flap back down to its original position and try to cover up on our veneers. These are resorbable sutures that are used. But you can see in the posterior regions how now that bone, by removing the horizontal component, the exostosis and buttressing bone, we now have much more level bony contours in those posterior buccal corridors.
So here you see a 1-month post-operative picture of the final restorations in place post-surgery. You see how we have all the margins are covered, soft tissue looks perfect, the restorations look great. We've really changed the position of the teeth in the patient's frame. We've done a great service to her in terms of she's had this aesthetic component from the very first day of preparation while she was in the temporaries. She didn't have to go through this long healing phase of the root exposure. And in the end, we used 2 different routes to get to the same end goal. And here you see the final face and the facial form of the picture, really taking away from the distracting cant of the maxilla, being able to take that away kind of in one visit and then following through with the surgery. Now, we're really, in this case, we've been able to control the aesthetic blueprint from the very first time we're working in the patient's mouth with the use of accurate provisionals, which I think is the most important aspect of any of these cases. And we've also been able to enhance the patient experience by giving her something very aesthetic from the first time she has been in the chair. So the question is, can we do this kind of innovative sequencing and take it one step further and take it into a full arch root coverage case, where we see patients that come in with this, where they have moderate to severe recession throughout their mouth, are going to need full arch grafting, but really are coming for the aesthetic concerns rather than the periodontal concerns.
So conventionally or traditionally, these type of patients would be evaluated by the restorative dentist, and prior to any restoration be sent to the periodontist to do root coverage to get the soft tissue regeneration over these roots prior to any restoration. The way that's done is, whether it's done with whatever type of procedure you want to use, whether it's connective tissue grafts or some sort of acellular dermal matrix, the problem is that usually there's going to be approximately a 90-day healing period prior to being able to begin your restoration. I mean, in terms of being able to pack any cord or do your preparation or go ahead and take impressions, you really want to let that soft tissue heal prior to invading it again. So there's the timetable. Restorative dentists feel that they lose all track of this patient. Patient's sent off to the specialist. 3 months of healing. The patient sort of forgets why they were even going to the dentist in the first place, which is really the key. Was their chief complaint was the aesthetics. And if you take a look at this patient, you see that she is not such a great patient. She's pretty frightened just to even have her photograph taken.
So in a case like this patient was very determined to get the veneers done. She was an out-of-town patient, so Brian and I had done a couple of these alloderm cases together, and we saw that we were getting such great results in terms of the stable outcome of where the tissue is placed after the time of surgery that I said, hey, let's try and prepare to the CEJ, and you bring the tissue down to the CEJ. The difference being is that rather than a provisional or an actual area of recession to the enamel being there, is the final veneer would be in place. So what we did was we prepared this case to the level of the CEJ on most of the teeth. I could use some of the recession if I needed to in terms of the apical height of the tooth, in which I did. And here you're seeing the provisionals in place, cut short of where the recession is, the root recession is. And then going back 1 week later and placing final restorations, and then allowing this patient to heal approximately 2 weeks prior to having any grafting done.
So now, instead of having to wait 3 months, the patient gets their chief complaint satisfied with the final restorations, and now I'm called upon to go ahead and try to bring this soft tissue down to the veneers. The other thing to realize that this is a patient that we've discussed, Mike and I discussed previously, and of course, if I was unable to bring the soft tissue down completely on any of these veneers, Mike had already told the patient that he would go ahead and replace it. So we're using this as our test case, and there are two things going on in this patient. One, she has a lot of root recession, but she also has some inadequate gingival quality in terms of the thickness of the soft tissue and keratinization that's present. So what are the objectives of root coverage? We want to cover the exposed roots, that of course we know. We want to try to obtain aesthetic outcomes for the restorative dentist and the patient, and we would try to enhance the zone of masticatory mucosa. We also need to deal with the inadequate gingival quality problems. We want to increase marginal tissue thickness. We also need to enhance the zone of immobile tissue. We always want to have dense connective tissue surrounding our restorations if possible. And we want to increase the dimension of the keratinized epithelium. So how do we make a decision? This is a very important situation for restorative dentists to know. This is a study by Serino that was done. And he said that if you have a patient that has at least 3 millimeters of recession, the chance that that's going to progress is approximately 67%. If you have a patient that has about 4 millimeters of recession, the chance that those sites will increase are about 98%. So just in terms of numbers, you don't need to have increasing recession, but if you see a patient with approximately 4 millimeters of recession, you can expect to see increased recession over that patient's lifetime. And it's something to consider prior to doing any of your restorations. So what are the real reasons to surgically treat these recession defects? If the patient, of course, reports hypersensitivity, that's a no-brainer. They come into your office usually telling you, this tooth is sensitive to cold, can we do anything about it? What about the situation when the patient reports aesthetic concerns? Again, very simplified because the patient wants those root coverage procedures to be done, if possible. And then the most important one is really when the clinician detects increasing recession or should be monitoring their attachment levels. So if you see a patient who is losing attachment, then of course it's increasing over time. This is somewhere where you need to go ahead and treat that. And then the one that we're dealing with is poor tissue quality for restoration as well as hypersensitivity for patients. So we're going to take this patient that Michael has already completed the final restoration, the veneers or the maxillary arch, and we're going to use a technique from Dr. Pat Allen in Dallas, who uses alloderm, acellular in a different technique. We do not make full thickness flaps as most periodontists are used to doing, but rather do a tunneling technique. This is a case we've done a while back, and today, in case we're usually doing full tunnels, in this particular patient, we did an alternate papilla reflection, so I got better access. But we did full arch coverage, and we had to bring this soft tissue down to the bone. So we really had to tunnel apically quite far from number 3 to number 14. If you take a look with the alloderm as it's been in place and stabilized and sutured, it's very nice and thick and very uniform, and see how well it adapts to those veneers. And it's sutured, in this case, independently from the outer flap. Today, there are techniques that Pat Allen has discussed that you can suture both the outer flap and the alloderm together. So here you see the outer flap that has been coronally positioned over the veneers to completely cover the alloderm, which is very important. If the alloderm becomes exposed, then of course you will not get the kind of root coverage you require, and also sometimes can get infection process beginning. So the outer flap is sutured independently in this case and coronally positioned over the veneers. Those sutures are polypropylene and they stay in the mouth for 4 weeks at least. They hold the graft as well as the outer flap intact. Here you see at 4 weeks when the patient came in for suture removal, we removed the sutures and you can see the nice root coverage we've achieved all along the veneers. Again, in the middle you see where the patient presented to my office with the final restorations. Looking at the full arch and the postoperative healing at approximately now 3 months, we see some more maturation in this area, and you can really view the dense connective tissue that we have up in this area above the veneers. The other thing that we're very delighted about is that we have no root coverage at all, no root exposure at all above any of the veneers. This is the pre-op, and then the patient in provisionals up to the level of the CEG, the CJ. Again, really, if you see the amount of recession in the cuspid and bicuspid regions, we're dealing with about 3, 4, and 5 millimeters of recession. And again, now look at the final healing process that's there. Let's take a look at the before. And you can see, and now the final restoration in place after approximately 6 months of healing now. So that's innovative sequencing. What have we done? Basically, we saved the patient about 3 months of healing and an immediate chief complaint that was able to be satisfied with her veneers. She actually lives out of town and was able to come in and get this done and then come back 2 weeks later and finish the surgical procedure. So you have to be able, case selection is very important when we're trying to utilize this. We don't try this on every one of our patients, but certainly in this case, it's a new innovative way of addressing patients that have root coverage and have as their chief complaint aesthetic concerns.
So just kind of summing up what we've gone through today, and you know, the most important thing is to try to kind of understand the clear direction of where we're going in the case. be able to bring our surgical specialists in to be on the same page in terms of where we want the final treatment plan to go, to decrease any confusion in communication between the restorative and specialist, the restorative and the patient, and the restorative and the ceramist, and then be able to execute all on the same page and trying to get that overall perfect result for each individual patient, to make sure the patient is happy, to make sure the patient feels that they've received exceptional quality of dentistry, and to be able to make sure the patient has gone through the dentistry smoothly. We hope you've enjoyed the presentation. If you'd like to contact us directly with questions, our emails are up on Dental XP website.